So, what do you think the topic is going to be? So, this is a topic on erectile dysfunction. So, this is a topic you want to know, but you want to know. Actually, it is not only from the lecturer, but also from the patient. This is the history you want, but many times you are embarrassed to ask this particular history from your patient, and also topic from your teacher or a lecturer or whoever may be. So, to give a brief introduction, since ancient times, the sexual health is considered to be a sign of overall health. Please remember, sexual health is considered to be a sign of overall health and good quality of life, and gained attention in the medical community in order to understand and helpfully improve it. Because if you improve your sexual health, it automatically means you have improved the overall health of the patient. So, when you go back into the history, apomorphine, the active ingredient of the lotus flower, is an effective remedy for erectile dysfunction and was used in aphrodisiac and possible cure for erectile dysfunction as long as 3500 years ago by the Mayans and ancient Egyptians. So, erectile dysfunction is not a disease of the recent era, it is a disease of ancient past, and also we have remedy from the ancient past. So, although talking about this problem is considered to be a taboo because accidental discovery that the cardiovascular drug, why this erectile dysfunction came into a very important focus, as I told you many times, when they developed the sildenafil, this is the Pfizer who developed the sildenafil. The sildenafil was first developed as an antihypertensive, as anti-anginal drug. So actually, the randomized clinical trials, 15 days or 1 month you give a steady drug and 1 month you give a placebo. And the investigators are surprised to find after 1 month of the active drug, when they gave the placebo drug, the people came back and asked them to give that drug they gave it the previous month. That led the investigator to find out, and this a particular drug is giving a very effective satisfaction or the erectile dysfunction cure. That's why the patients or the people who are participating in the trial refuse to go for a placebo arm. They want to remain in active arm. So that made the investigator decide to actually investigate in the other aspects of the drug, and that's why the sildenafil has become a drug for erectile dysfunction rather than an antihypertensive drug, also a antihypertensive drug. So from that drug, there is a great interest on erectile dysfunction, and the erectile dysfunction is actually, it's usually underestimated because it's a very common problem, and it's almost affecting 50% of men aged above 40 years, of course with a different severity, and increasing prevalence with the age. Although 50% is going to be around 40 years, it is going to be 60% in 50 years or 70% in 70 years, like that. So as the age advances, the prevalence is also going to increase. But basic thing is, you must understand, almost 1 in 2 above 40 has got erectile dysfunction. So why we are interested in erectile dysfunction in ECG and Echo Club of Trichy? This is a topic is not ours at all. This is not urological club. This is a ECG and Echo Club of Trichy. So cardiovascular disease and erectile dysfunction share the common risk factors. So we'll tell you the common risk factor, as you know, hypertension, diabetes, and so on. They not only share the common risk factors, they also share the common pathophysiological links, which means whatever the pathophysiological process which causes ED also causes cardiovascular disease. They are endothelial dysfunction, inflammation, aging, and low plasma testosterone. So these are the 4 important factors which not only cause erectile dysfunction but also cardiovascular dysfunction. Whereas these are the factors which are not only cause cardiovascular disease but also cause erectile dysfunction. That's why they share not only the risk factors, they share the common pathophysiological links. And it has been shown that the erectile dysfunction is a harbinger of cardiovascular events, and erectile dysfunction provide a very good window of opportunity to actually expect the coronary heart disease in future and take necessary steps to prevent a future coronary heart disease. So when you look at the information regarding cardiovascular disease and also erectile dysfunction, so now the clinical guidelines for CVD prevention or the CVD assessment started including erectile dysfunction as a means of assessing the cardiovascular risk and as well as support that particular entity to prevent a cardiovascular disease. And it is also shown to be a major contributing factor to the discontinuation of a cardiovascular drug. Because people say, because I take this cardiovascular drug, my erectile dysfunction is happening. So all the chances are that the patient may discontinue a very important cardiovascular drug for the sake of erectile dysfunction and at the danger of developing a cardiovascular disease emergency. And of course, another important thing we must also understand is, if you are treating an erectile dysfunction for the with a pharmacological treatment, so you not only get the benefit of erectile dysfunction, and it has been shown now, you will also have a significant benefit on cardiovascular system. So erectile dysfunction treatment is also going to benefit your cardiovascular system treatment. So what we are going to do in this lecture is to discuss how the sexual function, primarily focusing on erectile dysfunction in men, could be incorporated into patient's history. That's a very important thing. We never ask for erectile dysfunction in our history taking in any of your hypertension patients or diabetic patients or a known coronary heart disease patient. So that's why this lecture is important to why you have to incorporate the history taking of erectile dysfunction in your routine history of any disease you are dealing with, commonly hypertension, diabetes, cardiovascular disease and so on, not necessarily a routine diagnostic workup for a basic erectile dysfunction and treat it. And it is also going to focus on up-to-date evidence to help regarding the erectile dysfunction and cardiovascular disease, will help the cardiologist, will help the internist and also general practitioners. We hope that this lecture will help you, all of you, to understand the link between erectile dysfunction and cardiovascular disease and how you have to change your practice. So first of all, we look at how the erectile dysfunction and cardiovascular disease how they share the pathophysiology. So now the erectile dysfunction, especially in the young, let us say below 50 or 50 years, is called vasculogenic erectile dysfunction. So here it is difficulty in achieving an erection due to two important pathophysiological mechanisms. One is endothelial dependent and endothelial independent. Smooth muscle relaxation. So smooth muscle relaxation is very important for erection. So it can be endothelial dependent abnormality or endothelial independent abnormality. So this is called functional vascular endothelial dysfunction, because at the endothelial dysfunction you don't have anatomical abnormality. This is in early stages. Subsequently, what happens is, when the endothelial dysfunction goes on for years, there is a significant increase in the process of atherosclerosis, and these penile arteries undergo anatomical narrowing and make that endothelial dysfunction process almost a permanent. So that's why to start with early endothelial dysfunction and subsequently atherosclerotic narrowing of the arteries which are responsible for the erectile function. So we told you the four important factors of erectile dysfunction are endothelial dysfunction, subclinical inflammation, aging and androgen deficiency are the four important mechanisms of vasculogenic endothelial dysfunction. So the most important thing is the artery size hypothesis. So if you want to explain the connection between the erectile dysfunction and cardiovascular disease, and also you are trying to say that the erectile dysfunction will come before cardiovascular disease, the artery hypothesis is very important. So the disparity is likely to the result of larger diameter of arteries like coronary arteries or your cerebral arteries will able to tolerate some amount of atherosclerosis because they are in big size. The atherosclerotic plaque or the atheroma may not occlude that vessel for a long term. Whereas if the artery is small like penile artery, even a medium sized plaque or a small size atheroplatic plaque may obstruct the artery and they produce a endothelial dysfunction, and subsequently if the plaque grows and obstruct the big arteries only, you will have cardiovascular disease. That's why one important factor is the amount of plaque which is necessary to cause an obstruction or reduction of blood flow in the penile arteries may not produce an obstruction or any change in symptoms of in the large arteries, not large arteries like medium sized arteries like coronary arteries and cerebral arteries. Another important thing is you must understand the initial stages of endothelial dysfunction. The patient may not have a coronary artery disease at all because at this stage the atheroma has formed in the penile arteries. Because the atherosclerotic burden, the smaller penile arteries are obstructed before the larger coronary arteries. This is what I told you. So here the patient is completely asymptomatic on the coronary side, but you would have developed endothelial dysfunction which is causing the erectile dysfunction. So that's why endothelial dysfunction, even before your classical angina, is going to tell you that the patient has started penile angina, which is ultimately going to result in a classical angina of the coronary arteries. So if you look at the size of the artery and the clinical event you are going to have, the penile arteries are the smallest. So naturally your atherosclerotic burden is going to affect this artery first, and then will go on to the medium sized arteries like coronary and carotid. In coronary it may be CAD, or in the cerebral it may be stroke, or in the big arteries like femoral it may be claudication. The starting point will be happening in the smaller artery, which are the penile arteries. That's why it is understood that your erectile dysfunction may predispose to major cardiovascular diseases in future. The another important thing you have to understand the disparity of the endothelial surface. So erectile dysfunction and coronary heart disease are considered the two different clinical manifestations of the same vascular process are the same, but one is going to have erectile dysfunction, another is going to have a coronary heart disease. The erectile dysfunction would be predicted to precede, as we have already seen. Why endothelial dysfunction precedes coronary heart disease? Because of the size artery hypothesis. But another disparity is it seems that all the small penile arteries are going to have a large amount of endothelial surface than the big arteries, because the larger endothelial surface is necessary to produce a significant vasodilatation for the small arteries to make sure the erection is normal. Although they are small arteries, they are supposed to have a large endothelial surface when compared to the big arteries, because the vasodilatation should be very effective in small arteries. To have that very effective vasodilatation, they have a large endothelial surface. So that's why the same degree of endothelial dysfunction will produce an abnormality in the penile artery because they have a large endothelial surface. The same degree of endothelial dysfunction may not produce a significant problem in your coronary arteries and carotid arteries because they are not going to produce a significant problem in vasodilatation. So it is not only the size of an artery, it is also the endothelial surface which makes sure that your endothelial dysfunction is going to precede your coronary heart disease or cerebrovascular disease. So that is as far as the artery size is concerned and inflammation is concerned. The endothelial surface is concerned. Now we come to the second pathological link, that is inflammation. So the inflammation and prothrombotic activation is going to happen naturally in patients with endothelial dysfunction as well as in coronary heart disease. But in patients with a vasculogenic endothelial dysfunction, the inflammatory markers and endothelial prothrombotic factors are higher than in men who has got a normal erectile function. So that means the erectile dysfunction patients are going to have abnormal inflammatory markers on endothelial dysfunctional markers. And the amount of endothelial and prothrombotic activation in men with the erectile dysfunction is similar to a patient with a coronary heart disease. For example, if you take a patient with a coronary heart disease and estimate what is your CRP and what is your angiotensin, what is your endothelium, it is going to be the same for a patient with erectile dysfunction without coronary heart disease. So that's the importance of erectile dysfunction. So erectile dysfunction is supposed to have the amount of inflammatory abnormality and endothelial and prothrombotic abnormalities even in the absence of coronary heart disease, and the levels are going to be like a patient was already had an established coronary heart disease. So the low grade inflammation is very, very important, because the low grade inflammation is the one which is going to actually produce the thinning of the fibrous cap which is covering the plaque, and this is the one, and inflammatory substances like matrix metalloproteinases are the ones which are going to lyse the collagen of your fibrous cap, and because of that the plaque is going to rupture and you have an acute coronary syndrome or acute vascular event in the brain. So that's why, although the plaques are not vascular occlusive, even a non-occlusive plaque can be converted into vulnerable plaque to be ruptured because of the inflammation which is going to happen in endothelial dysfunction. So endothelial dysfunction can produce an acute coronary syndrome even before the manifestation of coronary heart disease is going to happen to the patient, because the same pro-inflammatory factors which are going to happen in coronary heart disease is going to happen in endothelial in erectile dysfunction. So basically endothelial dysfunction leads on to erectile dysfunction. So that's what we are telling, because they have a prominent role in erectile dysfunction, endothelial dysfunction. So what is going to happen in endothelial dysfunction? There is an imbalance between the bad substances and good substances. So endothelial dysfunction, your bad substances are going to be more, which are endothelin 1 and angiotensin 2, and the good substances are nitric oxide, prostaglandin E and C-type natriuretic peptide. So naturally your vasoconstrictors or smooth muscle proliferators are going to be more than the vasodilators, and smooth muscle antiproliferators are going to be less. So this is going to happen in perennial arteries, and that could be the most important common feature of erectile dysfunction. So when you look at, then we come to the next mechanism of androgen deficiency. So it has been shown that with a very big meta-analysis that the baseline plasma testosterone itself predicted the cardiovascular and all-cause mortality as well as the cardiovascular disease mortality. Most of the time we don't look at that, but now we know that the low level of testosterone can predispose a patient not only to the coronary heart disease but also its complications. So the capacity to predict cardiovascular disease depending upon the age and the plasma testosterone. So if you have a low testosterone in early age, it means that the patient is going to start to have an erectile dysfunction and subsequently going to develop a cardiovascular dysfunction. So this is a testosterone hypothesis. So we told you 4 things, and we have explained the 4 things as the main pathogenesis mechanism of erectile dysfunction, which is also linked to the development of a cardiovascular disease. When you look at the coronary heart disease and erectile dysfunction, they carry exactly the same risk factors. Whatever the risk factor which is going to produce coronary heart disease is going to produce erectile dysfunction. But very important thing you have to understand is the one risk factor for coronary heart disease is erectile dysfunction, and one risk factor for the erectile dysfunction is your coronary heart disease. We tell you subsequently how a coronary heart disease cannot lead on to erectile dysfunction. But that is an interesting phenomenon. Although they share the common risk factors, one is the risk factor for the other. Erectile dysfunction is the risk factor for coronary heart disease, and coronary heart disease is the risk factor for erectile dysfunction. That's why the people have started thinking erectile dysfunction is an independent marker of endothelial dysfunction and also early systemic vascular disease. It is not only a coronary heart disease, it may indicate a generalized systemic vascular disease. That's why the importance of erectile dysfunction. A very peculiar risk factor for erectile dysfunction is a long bicycle cycling or bicycle riding by the patients, especially with an abnormal seating. So a chronic bicycle rider may ultimately have an erectile dysfunction because of the significant compression of the sacral nerves, pudendal arteries. All these things may lead on to ultimately the vascular, endothelial, and neurogenic dysfunction. That's why now people are changing the bicycle seats so that they do not produce significant compression on the very essential body parts which are responsible for the normal erectile function. So having seen the link, now we come that we have now seen the erectile dysfunction can predispose to coronary heart disease, but many times both can coexist. So that's why when you look at the cardiovascular disease, you never look at the erectile dysfunction. You never look at the erectile dysfunction and have a particular method of treatment for erectile dysfunction, because many times your focus is to treat cardiovascular disease. I am going to tell you why this is not correct and why this is not going to give you a benefit on cardiovascular disease outcome. So we have a conventional risk factors to cause our cardiovascular disease. This we have already seen, and the erectile dysfunction also say the same risk factors as cardiovascular disease. But very important thing is, when the patient develops an endothelial dysfunction, there are certain unconventional risk factors which are going to aggravate your cardiovascular disease. So that is an important factor you have to understand. That's why in every cardiovascular disease patient, you have to look for erectile dysfunction, because the uncontrolled risk factors produced by erectile dysfunction, like depression, reduced frequency of sexual intercourse, and perceived reduction in love from a partner because of the decrease in sexual function, all these things are going to further complicate your cardiovascular disease prognosis. That's why if you miss your erectile dysfunction in the treatment of cardiovascular disease, still the cardiovascular disease outcome may not be good if you simultaneously treat your erectile dysfunction. The prevalence of erectile dysfunction is up to 75% in patients with a chronic stable coronary heart disease. That's why our approach is just to treat chronic coronary heart disease, and we don't actually divert our attention to erectile dysfunction, which is also creating lot of unconventional risk factors to aggravate your basic cardiovascular disease. So it has been shown when the patient has got an erectile dysfunction, even the patient becomes symptomatic on the cardiovascular side, there are significant markers of subclinical atherosclerosis. Although the patient is symptomatic on cardiovascular side, the patient with erectile dysfunction will have a high CRP, which is indicating inflammation, and they have a significant erectile dysfunction. They have the increase in atherosclerotic process in the form of increase in calcium in the artery and overall calcium volume, and also the calcification score of overall calcification score. So that means this also proves objectively that your endothelial dysfunction, automatically your subclinical atherosclerosis process is starting, and if it is not addressed properly, this will go on to the clinical manifestation of acute myocardial infarction or acute stroke or a peripheral vascular disease. So we already said this particular aspect, that the erectile dysfunction precedes the cardiovascular disease, and how much it is going to precede, how long before your cardiovascular disease, the erectile dysfunction is going to come. So it has been said, it is very easy to remember, it is going to precede by 1 to 3 years. For a single vessel disease, 1 year before erectile dysfunction happens. For 2 vessel disease, 2 years before erectile dysfunction happens. For 3 vessel disease, 3 years before your erectile dysfunction is happening. So this is very easy to remember. 1 year for 1 vessel disease, 2 year for 2 vessel disease, and 3 year for 3 vessel disease. So please remember, you need not have any manufactured coronary heart disease, but you always have subclinical or asymptomatic coronary heart disease if the patient has got erectile dysfunction. What is that magnitude of the silent coronary heart disease in a patient with erectile dysfunction? So it is said that the 21 in 5 patients with erectile dysfunction will have angiographically detectable coronary heart disease who are completely asymptomatic. 1 in 5 with erectile dysfunction. For the same analogy, if you do a coronary angiogram for a patient who does not, if you do a coronary angiogram for a patient, yes, if you do a coronary angiogram for a patient who does not have erectile dysfunction, the incidence of silent coronary heart disease is only 4%. So you can see the huge increase in asymptomatic coronary heart disease in patients with erectile dysfunction, which is angiographically. So it is not only erectile dysfunction which is going to complicate your cardiovascular disease, it is also going to complicate your heart failure. So among various manifestations of cardiovascular disease, one manifestation is heart failure, and we are going to see the link between the erectile dysfunction and heart failure. So it has been shown in some studies, in heart failure patient, the incidence of erectile dysfunction is as big as 70%. 70% of your heart failure patient may have erectile dysfunction. And if the heart failure is going to due to ischemic heart disease, the incidence is almost 80%. So that's why it is said that if you treat heart failure adequately, either with the drugs or devices, and you improve the left ventricular dysfunction, your erectile dysfunction also improves. That is a support theory to tell us that the prevalence of erectile dysfunction is related to heart failure, and treatment of heart failure is going to definitely improve erectile dysfunction. So then we come to the next important factor, whether it is going to be not only precedes your cardiovascular disease, and it is also coexisting with your cardiovascular disease like coronary heart disease and heart failure, and it is also going to predict. Now we are going to tell you what will be, how it is going to predict the prognosis of a patient with a cardiovascular disease. They are not only coexisting, not only the ED is preceding CVD, if the ED is presenting with the CVD, how your prognosis is going to be changed for a cardiovascular disease. So there are some studies which looked at the prognostic aspects of erectile dysfunction and cardiovascular disease in diabetes, and it is said that the erectile dysfunction is an important predictor of cardiovascular disease in these patients. So the big studies like the telmisartan studies have also shown that erectile dysfunction are at the high risk of developing a cardiovascular disease. So also the prognostic point. So definitely, although they are going to develop coronary heart disease, if the erectile dysfunction is going to present with the cardiovascular disease, there is a trend of increase in mortality in men with heart failure and erectile dysfunction when compared to a patient who's got a pure heart failure without erectile dysfunction. So definitely the presence of endothelial dysfunction is going to alter the prognosis of cardiovascular disease, and it can lead on to early death in a patient with a cardiovascular disease when it is pre-existing. So there is a huge meta-analysis and involving 1 lakh patients, involving 14 studies, and the duration follow-up of more than 6 years. A patient with a cardiovascular disease plus erectile dysfunction will have 62% increased risk of myocardial infarction, 44% increase in the risk of cardiovascular disease events, and 25% increase in all-cause death. So this is how the erectile dysfunction is completely going to alter your prognosis. And if you are not aware, and if you are not going to look at the erectile dysfunction along with the cardiovascular disease, although you are treating your cardiovascular disease with excellent drugs and whatever the guideline directed management, the subtle and silent erectile dysfunction is going to actually alter your prognosis in the form of increase in mortality and increase in morbidity. So that's why people are objectively now seeing what is the patient's, whether the patient with the cardiovascular disease has got objectively how to measure the erectile dysfunction, and this objective measurement of endothelial dysfunction, how we are going to predict the prognosis of a cardiovascular disease. So one best way of doing is to do the penile blood flow velocity, the dynamic penile peak velocity. If it is less than 25 mm/s, it is going to predict major adverse cardiac events in a general population of men and women with hypertension. So the hypertension patients who have got a low penile velocity will have 3.5-fold increase in cardiovascular event when compared to a patient with no hypertension. So even in a patient with no hypertension, that low penile blood flow velocity is going to predict major adverse cardiac equation in the patient who has already have a cardiovascular disease. If the patient has got a hypertension, the cardiovascular disease, the risk is higher. The normal penile velocity should be more than 35 millimeter per second. So this is an objective way of saying, in my cardiovascular disease patient, what is going to be my adverse cardiovascular event, although I am treating that patient with appropriate drugs and the modalities of treatment, the silent and subtle endothelial dysfunction is going to alter your prognosis. So the next important part is this: how your cardiovascular disease is going to affect your endothelial dysfunction. Now, the major causes of endothelial dysfunction, we already told you: the drugs, alcohol, bicycling, and of course the mental stress. So these are the 3 or 4 important causes of endothelial dysfunction, which is producing erectile dysfunction. So it's a very interesting phenomenon which has come into the knowledge, that the risk factor for acute cardiovascular event is that it is going to be attenuated. The risk of acute cardiovascular event is attenuated by habitual exercise and regular sexual activity. So that is actually reducing your cardiovascular event, acute cardiovascular event. On the opposite side, an acute cardiovascular event leads on to reduction in sexual activity, and also the reduction in sexual activity is actually going to increase the incidence of erectile dysfunction, and this ultimately will lead on to the poor prognosis of cardiovascular risk factors. So that's why a important message, and maybe a happy message, is that the habitual exercise and regular physical activity is a protector against a cardiovascular disease rather than a rare exercise and a rare sexual activity. So then we come to the cardiovascular ducts and erectile dysfunction, and it is said that many of your cardiovascular treatment will have a negative effect on erectile function. So main cause of erectile function most often is going to be your cardiovascular drugs. The cause of cardiovascular drugs will be the treatment of your cardiovascular disease itself. That will complicate the process. There is a higher prevalence of erectile dysfunction treated for hypertension when compared to a patient who has not getting treatment for hypertension. And the beta blockers and diuretics are notorious drugs to produce erectile dysfunction. But although we give lot of importance to these drugs, it has been shown, even though we call certain antihypertensives which are erection friendly, also can cause, just as ACE inhibitor, angiotensin receptor inhibitors, they can also to some extent can cause erectile dysfunction. So they are saying that no antihypertensive is not going to be actually good for your erectile dysfunction, because although beta blockers and diuretics are the notorious drugs which are going to produce an erectile dysfunction, even the drugs we think we are erection friendly may also cause erectile dysfunction. So it looks like little bit confusing statement, how my ARB or a calcium channel blocker which is actually acting against endothelial dysfunction is going to increase my erectile dysfunction. That is because the significant drop in blood pressure by your antihypertensives is going to decrease your penile blood flow, and because of the penile blood flow is going to be reduced, and it is going to cause the erectile dysfunction. So number of antihypertensives you use, and it is related to large deleterious effect on the sexual function. So that's why when you compare the antihypertensive like beta blockers and diuretics, they have a different mode by which they increase erectile increase the erectile dysfunction, whereas even other antihypertensive drugs can produce erectile dysfunction because of the excessive drop in blood pressure, which is actually reducing the penile blood flow. So that's why we have to elect drugs in erectile dysfunction. So there are a lot of studies which said which drug is good and which antihypertensive is good, and which antihypertensive has got a beneficial effect on sexual dysfunction, and which antihypertensive drugs are not going to have a good effect on this. So taking out different classes of various antihypertensive drugs on erectile dysfunction, the crucial question is that whether the physician is going to switch to one class to the another, even change from one agent to other agent in the same class, to improve the erectile dysfunction. For that, we must have a very good idea of our antihypertensive drugs we use and their effect on the erectile function. So now I am going to give you some of the studies which studied number of drugs on the erectile function of the heart. So when they compared the quinapril and placebo, both improved the erectile function. Even placebo improved the erectile function when compared to the quinapril. When in hypertension, when they compared the telmisartan and rapamypril, both did not have any effect on erectile function. Whereas when they compared the erectile function in hypertension metabolic syndrome with irbesartan and valsartan, both these two ARBs improved erectile dysfunction. So if at all you want to use an ARB in the presence of erectile dysfunction, it is likely to be irbesartan or valsartan and not telmisartan. So when you come to the alpha blockers in hypertension, doxorubicin and placebo, and there is a slight positive effect for doxorubicin and not for placebo, a small effect of alpha blockers. So when you come to the beta blockers, which are very notorious drugs to cause erectile dysfunction, so what is the effect of beta blockers when they are used in coronary heart disease, especially atenolol, on erectile function? They significantly decrease erectile function and potential adverse effects, so definitely they are contraindicated. So if at all you have so if at all you want to use a beta blocker and there is a definite indication for a beta blocker, you cannot stop a beta blocker. At the same time, you do not want to increase your erectile dysfunction problems, it is likely to be nebivolol. In many of the trials, the nebivolol has been shown to improve the erectile function, or the decreased and erectile dysfunction is less with a nebivolol when compared to the meta blocker for any other beta blockers. So that's why the nebivolol is going to be the beta blocker of a choice in a patient with erectile dysfunction, where you have to use a nebivolol for a particular cardiovascular problem or hypertension. So as far as the calcium channel blockers are concerned in hypertension, when they compared amlodipine and enalapril, both produced the improvement in erectile function. When they compared felodipine and irbesartan, the combination produced better improvement in erectile function than the individual drugs alone. So the combination of felodipine and irbesartan may be a good combination to improve erectile function. Of course, when you compare the diuretic, thiazides are going to significantly decrease your erectile function, and they are going to decrease your erectile function more than your beta blocker. So between diuretic and a beta blocker, thiazide is more notorious to reduce the erectile function when compared to the beta blocker. When you come to the aldosterone antagonist, the mineralocorticoid receptor antagonist, eplerenone is also supposed to decrease erectile function, but when they compare eplerenone versus spironolactone, eplerenone is slightly better to preserve erectile function when compared to the spironolactone. As far as the statins are concerned, that when you use a statin, especially atorvastatin, may have a modest improvement in erectile function and not rosuvastatin. So if at all you want to use a statin in erectile function dysfunction, this has to be atorvastatin. So as far as the antiarrhythmic drugs are concerned, we already told you about the beta blocker. Then we talk something about digoxin. Although you think that digoxin is going to improve your contraction and going to increase your cardiac output and going to improve your heart failure, you expect the digoxin to improve erectile function, but it is not going to do so. It is also going to produce erectile dysfunction because they are interfering with the production of testosterone, and they are going to produce its inhibition on a corpus cavernosus, thereby the nitric oxide induced vasodilation is decreased by digoxin. So that's why if we want to use a drug for reduction of heart rate in your heart failure patient as well as coronary heart disease patient who has got an erectile dysfunction, it is preferable to use an ivabradine. Or if you want to use a beta blocker, it has to be nebivolol. So now the interesting aspect is we have looked at a cardiovascular disease treatment and also the erectile dysfunction. So the next important question is whether your treatment of erectile dysfunction itself is going to either increase the cardiovascular risk or decrease cardiovascular disease. That means whatever the drugs you are going to use for endothelial dysfunction is going to be bad for the heart or the good for the heart. Now, for that we look at the sildenafil, which is the very effective drug, which is one of the very important and first drugs to be used in erectile dysfunction. How they are going to act? As you can see, when the nitric oxide is produced and into the pineal arteries, what they produce is they produce guanylate cyclase, which is going to convert the GTP into cyclic GMP, and this cyclic GMP is the one with the through protein kinase G is going to decrease the calcium inside the cell and thereby produce vascular relaxation and pineal artery dilatation, and which results in erection. So this is how anything will increase the cyclic GMP will increase the erection. Whereas what this cyclic GMP is going to be degraded by phosphodiesterase 5. So that phosphodiesterase 5 is going to degrade your cyclic GMP. So if you have excessive PD5, it will decrease GMP, thereby decrease vasodilatation, decrease erection. But what the sildenafil and other PD5 inhibitors are going to do is to block this PD5 inhibitor, which is going to degrade cyclic GMP. So you have a significant increase in cyclic GMP because the degradation is altered or degradation is reduced. So that will result in more vasodilatation and more erection. So this is the manual of the methodology of function of sildenafil. So definitely it has been shown the sildenafil is confirmed the safety on cardiovascular disease. When you use sildenafil provided in a particular patient, a well evaluated patient regarding his physical activity, their level of angina and so on, they are not going to definitely increase your cardiovascular events such as myocardial infarction. They are relatively safe in a patient with a cardiovascular disease. But the most important problem is the drug interaction. So when you use sildenafil or the related PD5 inhibitors, there are three important drug interactions on cardiovascular disease. One is nitrate. You will never use a combination of sildenafil and nitrate. Second is an alpha blocker. And third is the newer drugs which are called soluble guanyl cyclase stimulators. As you know, the guanyl cyclase stimulator is the one, the guanyl cyclase is the one which actually converts into GMP. So when you stimulate this guanyl cyclase, you have more GMP to be formed. So the guanyl cyclase stimulators are the two drugs, Resiguvat, which is used in pulmonary hypertension. Now we have Versiguvat, which is used in refractory heart failure or worsening heart failure. So you can never use a PD5 inhibitor such as with these three drugs, namely the nitrate, the alpha blockers, and also the soluble guanyl inhibitors you cannot use. So, but when you use this particular PD inhibitor with other antihypertensive drugs, there may not be any synergistic effect or excessive BP lowering effect because you are adding the sildenafil with a pre-existing the antihypertensive drugs like calcium channel blockers, ARB or diuretics. The caution is the most important caution is combining nitrate with a PD5 inhibitor. So it is strictly contraindicated, and that's why we always say before we give a sublingual nitrate to a patient who has got an ACS or acute coronary syndrome, you have to elicit the history of sildenafil use. If the patient has got taken sildenafil in the last 24 hours or patient has taken the tadalafil for the last 48 hours, you should never give a nitrate even though the patient has got an acute coronary syndrome. So why the nitrate and sildenafil combination is so bad? For example, what the sildenafil done, what sildenafil is doing is to prevent the degradation of cyclic GMP by inhibiting phosphodiesterase inhibitor. So they are significantly increasing cyclic GMP by preventing its degradation. Whereas the nitrate, by donating more nitric oxide, they are going to increase the production of cyclic GMP. So when you combine sildenafil and nitrate, sildenafil is going to decrease degradation, nitrate is going to increase the production. So you have a huge increase in cyclic GMP, which will ultimately produce a huge vasodilatation and resulting in a refractory hypertension. So that's why now when you look at the PD5 inhibitors, They are not only today used in erectile dysfunction, the most important indication today is in pulmonary hypertension and also recurrent urinary tract symptoms, lower urinary tract symptoms. These drugs are used. So today, three important indications are this, but we are expecting many indications like in diabetes and also the neurodegenerative diseases, cardiovascular disease, cancer, and obesity. So what happens to the alpha blockers and the sildenafil? You can use, but you have to use it with caution. When you want to use alpha blocker, and it is preferable to prevent, but when you have to use an alpha blocker, especially for a prostate, you have to use the uro selective alpha blocker, and you have to have a 6-hour time interval between your sildenafil and also the alpha blocker. By which, when you are combining these alpha blocker with sildenafil, give sildenafil in the morning and give this alpha blockers in the night. So this is as far the safety is concerned or the drug interaction is concerned. So the important question is, when you are treating ED with these PD5 inhibitors, whether they are going to alter or give the benefit on the cardiovascular system, and this evidence is growing. That's a very good sign. So these PD5 inhibitors are going to decrease endothelial dysfunction. They are also going to reverse the vascular aging, and they are going to decrease inflammatory activity, and they are going to increase the hemodynamics. They even reverse left ventricular adverse remodeling and improve diastolic. So there's a lot of good things which are going to happen in the cardiovascular side when you use these PD5 inhibitors. So the PD5 inhibitors are not going to emerge as the drugs for the erectile dysfunction, and they are also going to be the drugs for endothelial dysfunction, and they are going to be also drugs to be used in cardiovascular disease in future. So with this we come to takeaways, and this is the very statement even as early as 2006. It is said by Princeton that recognition of erectile dysfunction as a warning sign of silent vascular disease has led to the concept that a man with erectile dysfunction, even though he has got no cardiac symptoms, is a cardiac patient until proven otherwise. So even 2006 it is said erectile dysfunction is cardiovascular or coronary heart disease risk equivalent. So many risk equivalent we talk about. We talk about peripheral vascular disease as a coronary heart disease risk equivalent. We talk about diabetes as a coronary heart disease risk equivalent, and also the erectile dysfunction. People are saying it is a coronary heart disease risk equivalent, by which we mean whenever erectile dysfunction is there, you have to treat like a coronary heart disease by controlling the risk factor and also by giving appropriate treatment. So what is a very important message by this? So very important strategy in all our hypertension patients and cardiovascular disease patients is that ask routinely about erectile dysfunction. But of course it's a very embarrassing situation or very rare situation where we can ask openly about the sexual function of the patient who has got hypertension or established coronary heart disease or cardiovascular disease. And there are certain polished terms or polished sentences you can use to get the history of erectile dysfunction. So we can ask, it is quite normal for some patients with a cardiovascular disease to experience problem in the sexual function. Is it affecting you? And you want to tell me something about it. And we can generally say some function may, I have seen many patients after bypass surgery telling me about their problem in sexual function. Do you have anything like that? So in this polished way, we can elicit the history of erectile dysfunction and start addressing it. So the sexual health is very important for the overall cardiovascular health. That's what we have to understand. So to get a very good cardiovascular health, you have to first get a good sexual health. So the ED not only stands for erectile dysfunction, it stands for endothelial dysfunction, it stands for a window for opportunity to detect early detection of risk factors, and it also gives opportunity to early diagnose a vascular disease, and also modify your risk factors like exercise and diet, and also it will give you a chance to elect drugs in the cardiovascular side to definitely make sure that your erectile function is not altered by your cardiovascular drugs. And also, when you do all that, you will prevent the patient to go into emergency department, and also you will prevent early death. So now we have to understand the erectile dysfunction is no longer in the brain, no longer it is a psychological factor, no longer it is a psychological treatment which needs erectile dysfunction treatment, especially when the patient is below 50 or 55 years. So what is very important message from this particular lecture is erectile dysfunction predicts, precedes, presents along, and also prognosticate a patient with coronary heart disease. It is also complicates coronary heart disease, not only the disease but also the drugs we use for coronary heart disease. And we also must remember the coronary heart disease itself may complicate erectile dysfunction because of the drugs we use it for hypertension and also the coronary heart disease. So this is an important message we have to understand. So a very important message is that erectile dysfunction is an important factor to be considered in all patients with hypertension and also established coronary heart disease, be it a chronic CAD patient or a post-revascularization patient. We have to routinely ask the factors or the messages regarding erectile dysfunction and start addressing it. Thank you for your patience.
Thank you, sir.
Thank you, sir. Thank you, sir.
Thank you, sir. Thank you, sir. So let me
Recording stopped.